Is the president or secretary or president-elect is likely to attend, Goan?
No word as of confirmation yet, sir.
Okay. You have mentioned to Ellen, no?
All the faculty invite mails have been sent to them, sir, and the EC members as well, sir.
Perfect.
Sir, it's 7:32, sir.
Perfect. Shall I start?
Yes,
So,
sir, please.
hello, good evening, everybody. A warm good evening to all of you, including our IN President, Secretary, President Lakshmi Narasimhan, Secretary Meenakshi Sundaram, President-elect, the man in neuroetology, Sudhir Kothari, uh, the chair of NeuroRehab Subsection, Guhan, and Ramakant Pandey, Abhishek Srivastav, and the speakers of the day today, Vishal Pawar, Ms. Nayak, and Dr. Dorsala. We all know that vestibular system is like a compass, and it control the balance between vision, somatosensory, and all these three systems are the one which maintain the balance of a man. And if there is any disturbance in this system, then you know that your compass has been disturbed. You may get dizziness, imbalance, fear of falling, not able to, do your work regularly. And that is what precisely we thought that the most neglected part in the neurorehabilitation and the most exciting part in the neurorehabilitation is vestibular rehabilitation. And we had a balance between neurology, neurotology, and neurophysiotherapies today to give you how the multidisciplinary team can work together to make a person who otherwise could be incapacitating, immobile, back into the work. Vishal Pawar, who is a consultant neurologist from Dubai, will talk about the how the basics about the vestibular system and the rehabilitation, and the Sheetal Nayak, who works along with Vishal on give us the practical insight on how does one could treat them after the therapy. And not to forget Dr. Dorsala, who is an ENT surgeon and neurovestibular specialist, will tell us about how are the measures, how to do the interpretation from basics, and there will be a quiz. So be prepared for that. This is going to be very exciting, and I'm very keen to hear all of them. And Pathshala is something which is entirely a different course. It takes you back into the olden days when the guru used to teach, like in our Marwadi, it is used to call gurus, Gorsala or Gurusa. And this is basic teaching, and I'm sure you all are going to love it, not only from India but across the world. So over to you, Guhan.
So thank you very much, sir. And indeed, it is a great privilege first of all, I would have liked to introduce Dr. Nirmal Surya, sir, though the whole of Neuro Rehab fraternity knows him. And it's a proud moment as a mentee to introduce my mentor. He is the past president of Indian Academy of Neurology and Indian Stroke Association. He is the president of Indian Federation of Neuro Rehabilitation. He is the president of Asian Oceanian Society of Neuro Rehabilitation and the secretary general of the World Federation of Neuro Rehabilitation. And there cannot be a neuro rehabilitation that is meaningful enough without him at the helm of the leadership. We welcome you, sir. Thank you so much for taking forward this initiative and helping many along the path, sir. And it is with immense pleasure that we also share that we have crossed 1,000 registrations from across 24 countries for the episode 3 of Neuro Rehab Pathshala, sir. And with that, without wasting any more time, because Surya sir tells, go straight to the target, don't beat around the bush. So let me start introducing the panelists for the day. Can we have the introductory slides that I sent you last, Asmita ma'am?
Sure, sir. Please share.
Ma'am, can you share that, ma'am? Next slide, please, ma'am. So we have with us today Dr. Vishal Pawar, sir, the specialist in vestibular rehabilitation and vertigo from Dubai. He has completed his special certification, fellow of European Board of Neurology and vestibular certification from the American Institute of Balance. He heads the Tarabichi Vertigo and Balance Center in Dubai. He is the chair of the neuro-otology subsection of the Indian Academy of Neurology with over 38 peer-reviewed publications and his name printed all over the vestibular system. It is indeed a great pleasure to have you here and the best person to discuss about the vestibular rehabilitation today, sir. And I introduce our neurophysiotherapist, the vestibular rehabilitation specialist. Can we go to the next slide, ma'am? Dr. Sheetal Nayak, who is a vestibular physiotherapist at the Tarabichi Vertigo and Balance Center in Dubai. And her area of specialization includes vestibular rehabilitation, expert managing complex cases of vertigo, BPPV, PPPD, and vestibular migraine in close collaboration with the multidisciplinary team. And she would be taking us through all the cases. We are going to introduce Dr. Srinivas Doshala, the ENT specialist, ENT surgeon, and the vestibular person. And he is a man who is not just reading into the graphs, but started creating the equipments that is responsible for these tracings. And he is an honorary professor at Jawaharlal Nehru Medical College, adjunct faculty, Anapoya University, Bengaluru, and a very great orator and speaker. We welcome the panel from across the globe, specialized in vestibular rehabilitation. Without wasting any more time, I hand it over to Dr. Vishal Pawar, sir. Over to you, sir, for
Yes.
from the basics to the mastery.
Yes. So I'll share my screen. Thank you, Dr. Gohan, for that kind introduction. Thank you, Dr. Surya, for his continuous guidance. He has guided me all these years and giving me opportunity to talk in various prominent forums like World Federation of NeuroRehab, European Federation of NeuroRehab, and today I'm talking here in Indian Federation of Neurorehabilitation. Good evening, everyone. So today I'm going to talk on from basics to rehabilitating vestibular disorder, from basics to mastery. So I have nothing to declare, and I have taken informed consent from the patients which are shown in the presentation. So this is my topic. I will cover initially the basics and then go to the mastery. Now, we all know that we have five special senses, that is taste, hearing, sight, smell, and touch. And unfortunately, we are less aware about the balance control system, which is a sixth sense. And we realize the presence of vestibular system when we lose it. Like whenever there is a vestibular dysfunction, then only patients especially realize that there is something called vestibular system, and it is one of the very important sense. So in nutshell, there are five vestibular end organs. Uh, that is two otolith organs, utricle and saccule, and three semicircular canals, that is anterior canal, posterior canal, and lateral canal. So the impulses or the sensations from the anterior canal, lateral canal, and utricle go to through the superior vestibular nerve, and saccule and posterior canal, the vestibular sensation go through the inferior vestibular nerve, and both these branches form the vestibular nerve. And the vestibular nerve is joined by the cochlear nerve to form the vestibulocochlear nerve. The vestibulo-ocular reflex, which is very important for clear vision, it starts from the vestibular nucleus and it connects to the ocular motor nuclei. And the vestibulospinal reflex starts from the vestibular nuclei, connects the anterior horn cells for the postural adjustments in the neck, limbs, and the trunk. Now, when the pure vestibular sensations, which is coming from the vestibular system, and we usually learn that it carries linear acceleration and angular acceleration. But is it that simple that it is just linear acceleration and angular acceleration? No, what happens is these vestibular sensations, when they go into the brain, starting from the vestibular nucleus, the processing of the vestibular signal starts, and the vestibular signal is interpreted into spatial orientation by multisensory integration with vision and proprioception. Then the navigation function, we have innate navigator in the brain, that is the central vestibular pathways, which tells us where we are heading, and what is the destination and what is the path. So it's a very important system. It's also important for clear vision, because when our head is stable, only optic nerve is needed. But when we move our head, we need optic nerve as well as the vestibular connections, the visuovestibular connections, for maintaining the clarity of vision. Gravity sensation is also another function of the like vestibular system. I tested my gravity uh, doing the skydiving, and the otolith organs are very important for sensing the gravity all the time. And it is also a speedometer. The speedometer of our body, we can say, that is otolith organs, and it helps to know the speed. And the postural adjustments are important in various situations. I would like to declare that this is not me, but of course I was here in skydiving and the zip line. Now, coming to the requirements for spatial orientation. So basically, the aim of the vestibular sensation is, one is gaze stabilization for clarity of vision. Head stabilization is also important for, again, clarity of vision, and postural adjustments are very important. So let us see how various inputs and reflexes are important for this. So the vestibular input coming from the vestibulo-ocular reflex is important for the vestibulo-ocular reflex is important for the gaze stability, that is stabilization of the gaze despite of the ongoing head movement. The vestibulo-colic reflex is important to stabilize the head whenever there are vestibular sensations. It helps to stabilize the neck also. This vestibulo-colic reflex is very prominent in chickens, and you can see, despite of the ongoing movements, the chickens, they can stabilize their head because of the vestibulo-colic reflex. Then comes the vestibulospinal reflex, is important for postural control or postural stabilization. The neck proprioception also plays a role, but lesser in human beings for ocular stabilization. It has little contribution in the form of cervico-ocular reflex. That's why many patients with vestibular disorder develop neck muscle spasm, which is secondary due to activation of this cervico-ocular reflex and cervico-colic reflex. So head stabilization is done by the neck proprioception uh, inputs, and it stabilizes, helps to stabilize the neck muscles. The cervical proprioceptive inputs are also important for posture stabilization, that through cervicospinal reflex. Vision, whenever our visual inputs are not stationary, they are moving, then comes the role of smooth pursuit and optokinetic reflex for the gaze stabilization. And head stabilization is by visual feedback, and posture stabilization is also by visual feedback. Now, coming to the vestibular system on one side versus the other side, there is something called as push-pull mechanism the vestibular system on one side is trying to push the trunk, the limbs and the eyes towards the other side, and so also the other side is doing the same. So whenever there is a, suppose you imagine that the patient left vestibular system is hypofunctioning, especially the lateral canal, then the patient will have right beating nystagmus, because the slow phase of nystagmus will originate from the because of the right sided push, and then there will be a correction, and the patient with left vestibulopathy will have right unidirectional nystagmus, and the patient on Unterberger's testing will deviate towards the left side, to the involved side. Now coming to the mastery, there are various aspects of like mastering the vestibular rehabilitation. The first is history taking. The quality of symptom is very important, whether it is vertigo, dizziness. Vertigo is any sense of movement when no movement is happening, or sense of distorted sense of movement. Dizziness is a kind of spatial disorientation. Vestibulovisual symptoms are nothing but oscillopsia, movement-induced blur, and there are variety of gait abnormalities or postural abnormalities like unsteadiness. Then the timing and trigger are very important in diagnosis. Suppose it is less than a minute and it is positionally triggered. Most common differential is BPPV. And if it is spontaneous and the duration is 5 to 72 hours, it is vestibular migraine. Accompanying symptoms are important for diagnosis. We have to define the syndrome, whether it is acute vestibular syndrome, episodic vestibular syndrome, or a chronic vestibular syndrome, and it helps to cone down our differential diagnosis. Now coming to the examination of the vestibular system, there are variety of modalities like the head impulse test we can do. Then the skew deviation alternate cover and uncover test for in acute vestibular syndrome. Then the gaze testing, like spontaneous as well as the gaze testing, like whether the patient has any gaze evoked nystagmus. You can see the patient has right beating and with down beating component on right gaze, and left beating with down beating. So it is a typical gaze evoked nystagmus. So examination is very important in vestibular. Now here I'm performing the positional testing. This is a Dix-Hallpike testing initially, and this is a head roll or head yaw test for the lateral canal. And then comes the postural examination. That is, we do the eyes closed with firm surfaces Romberg's, but eyes closed with the foam surface is vestibular examination we can perform in this during this particular testing. Now let us come to know about let us discuss about the various vestibular tests. Now, like why I'm showing audiogram is audiogram, if we do, there is a frequency spectrum of the sound, like ranging from suppose 125 to 8K hertz. Similarly, the vestibular system also has frequency spectrum. In audiogram, in one shot, you can check, one test, you can check all the frequency spectrum. But in case of vestibular system, you have to, low frequency is tested by lateral canal, the mid frequency by rotary chair testing, the head impulse checks the 3 to 7 hertz, and the skull vibration checks 100 hertz, vestibular system at 100 hertz. So there is a frequency spectrum, and there are variety of tests which are done for different localization. For example, positional testing, V hit, F hit is done for semicircular canal localization. Otoliths are WAMP, SVV, they are for otolith localization. Imaging we do for brain localization, and VNG and V hit also can have mixed finding, like it can show us findings of central as well as peripheral abnormalities. Now, this is the entire spectrum of testing what we use in our practice. The most important thing I would like to tell here is vestibular testing gives us findings. It doesn't give us diagnosis. And in vestibular rehabilitation, which we are discussing, it's very important that there are certain tests which are especially not for diagnosis, they are for identifying the functional deficits of the patient. For example, the posturography, video head impulse test is for identifying vestibulopathy, and then you can give a specific rehabilitation tailored to that particular canal involvement. If the patient has vamp abnormalities, you can go ahead with otolith or saccular exercises. So basically, the aim of the vestibular testing is not just diagnosis, but it is about knowing the functional deficits, and along using that functional deficits, measuring them to plan the vestibular rehab. And especially also the various protocols can be used as a rehab tools also. For example, VNG, the saccade smooth pursuit optokinetic can be used as a rehab tool also. Now coming to the physiotherapy assessment, uh, like we assess the three aspects of during the vestibular rehabilitation. These are first the individual specific factor, whether the patient is having postural symptoms versus movement induced symptoms. Then we identify environment, like whether the patient is getting visually induced symptoms like in crowded places, malls, or height phobia, and different kind of situations. And we can give different tasks like like various tasks like walking, timed up and go. So vestibular rehab assessment is very important because the VRT, vestibular rehabilitation, is not about the diagnosis. It's about the measuring the deficits and working on the deficits. So diagnosis is one part of the workup, but we also need to measure the deficits and to work on them. So the patient's dizziness handicap inventory is very important, which assesses functional, emotional, and physical impact. The timed up and go test is very important for assessing the balance, the functional impairment, and functional motility and balance. And then comes the dynamic gait index for assessing the dynamic balance and gait. Then we check the modified clinical test of sensory interaction, or like the most the very important, like the appropriate name is test of sensory denial. That is to know the sensory integration of the balance between visual, vestibular, and the somatosensory. Then head impulse test is a very important test to like identify the deficits involving all the six semicircular canals, and then we can work on those deficits with the video head impulse test especially. Then comes the dynamic visual acuity, where the patient's head is moved and we can check the vision, uh, because vestibular system is important for visual acuity when we are moving the head. It's not just about the only visual system. Then there are variety of scales like visual vertigo analog scale for visual motion sensitivity, computerized dynamic posturography for sensory integration and postural stability. VAMP and subjective visual vertical is important for otolith function, and PHQ-9 and GAD-7 are important to assess the anxiety and depression. So variety of scales are there. You have to tailor, according to your requirement and patient requirements, and it's very important to use these scales for assessing the physiotherapy requirement, vestibular physio requirement. Now, the next important thing is customizing the physiotherapy plan according to the patient need. It is, we are in an era where it is not just about giving a fixed set of exercises to the patient. It is about the identifying the dominating defect, whether it is VOR weakness or gaze instability, whether it is unilateral. Then you go for adaptation exercises, that is VOR1 and VOR2. If it is bilateral, severely, severe and poorly compensated, then the patients need substitution strategies. If I see a lot of patients who have bilateral vestibular loss involving both the lateral canals and in variety of combinations, they need substitution strategies. Then movement induced, if the patient complains, typical situation I would say is post BPPV dizziness. We use the Brander of exercises in after canalith repositioning maneuver for treating the post BPPV dizziness. Of course, you have to check whether the patient has residual BPPV. Visually induced dizziness is treated by optokinetic training and visual motion exercises. So we have created a dark room for this treating this visually induced dizziness, which is very common. Visual or surface dependency, we have to go for sensory reweighing exercises. Postural instability, we need to go ahead with static and dynamic balance exercises. Walking and turning difficulty, the patients need functional gait training. And avoidance or triple PD pattern, if we see, then the graded functional exposure, for example, a person has a problem with supermarket, then we can give this through virtual reality, or tell also the patient to spend graded more time in supermarket, slowly increase that time. So it's very important to do this so that they can go back to their normal function. Psychiatric disorders, if the patient has, then they will benefit by emotional healing. And there are certain techniques you can do, like breathing exercises, compassionate body scan, or guided shavasana. So there are like they also benefit by doing the rehabilitation, some of the rehabilitation strategies. Now coming to the one particular entity which is very common here in Dubai is motorist vestibular disorientation syndrome, and I'm proud to say that we have one of the world's largest registry of this. And I proposed the diagnostic criteria for this disorder in 2023, and the patients feel symptoms on high speed bends and turns, multi-lanes, slopes while overtaking a big vehicle. And we do this something called as this car simulation. Like we have a car simulator where the patient uses virtual reality goggles, and we simulate those scenarios and we train them, along with, of course, the multi other treatment modalities also, like medicines and other lifestyle changes. Now, there are certain special situations like mal debarkment syndrome, where we use this optokinetic training with head roll. Dr. Sheetal, who is going to follow me, she will show the other exercises in detail about the other case, but we do specifically this MDDS optokinetic training with head roll, and we are achieving very good outcomes with this. And we also use virtual reality for treatment of situation specific dizziness, like motion sickness, triple PD, or agoraphobia, height phobias. Uh, so we have to tailor. This is the menu card of vestibular rehabilitation. Of course, there are many more modalities which are not mentioned here, but we have to order what is needed, whether the patient has BPPV, canalith repositioning, balance training if the patient has postural issues, virtual reality, optokinetic training, rotary chair, vibration, a driving simulator. So we have to tailor the according to the patient specific need. One size doesn't fit all. And lastly, this is my second last slide. We have to do periodic re-evaluations, modify the protocol, measure the outcomes, because the outcome is non-linear. It is dependent on patients, whether they are doing home exercises. And it's very important to recalibrate, because sometimes it can aggravate. So it's very important to progress slowly. And with that, this is my summary slide. Vestibular rehabilitation does wonders. Identify physiotherapists who are interested in vestibular rehab, train them, motivate them to do rehabilitation courses. Start slow, progress slowly. You can start without equipment and build up the this, facility, and design customized vestibular rehabilitation programs, and you will see wonders in your practice, because it's not just about medicines. It's all about, rehabilitation also. Means it is a holistic approach. So with that, I end here. This is our facility. If you happen to come to Dubai, please visit our rehabilitation and vestibular setup. This is my email if there are any questions, if there are any guidance you need. Thank you so much. Thank you.
Thank you very much, sir, for the wonderful summary of the vestibular rehabilitation. And any words from the chair, Dr. Surya, sir?
There are a couple of questions. Let me see.
Shall we take the
Not,
question, sir?
yeah, we can take one or two questions here. One is how where to buy the lenses Pharyngeal, you have any suggestion on pharyngeal lenses?
So there are variety of pharyngeals available. It's very important to check what is available. And there are like Dr. Srinivas has some pharyngeal glasses. Michael Stroop has M glasses. So there are variety of vendors who from where you can buy these pharyngeal glasses.
Another question for you is, isn't the association of long distance navigation with vestibular apparatus is perhaps questionable?
See what happens when the vestibular sensations come, they get intermixed with visual vision as well as somatosensory sensations. So when we are navigating somewhere, there are something called as place cells in the hippocampus, which are connected with the vestibular apparatus. They help us to tell where we are located. And there are direction cells also, head direction cells, where they help us to know how to navigate to that particular area. Just one example I'll give. If you go to stay in a hotel, new place, and you just look at the facility and you just suppose you are aware where is the washroom located, and when you lie down and get up in the morning, you even without opening the eyes, the vestibular system knows where is the, how to navigate to that path. It is not just about vestibular system, it is about multisensory, of course. So vestibular system plays a very important role in navigation.
So we move on. Guhan.
Okay, sir. So with that, we will proceed to the next talk, extrapolating from the vestibular rehabilitation to case-based discussion of vestibular rehabilitation. Over to you, Dr. Sheetal, now.
Yes. I just share my slide. Is my slide visible?
Yes, ma'am.
Yes,
It's
ma'am.
visible, ma'am.
Okay. Just a minute. Okay. So good evening, everyone. It's a pleasure and a privilege to be here. I'd like to sincerely thank the Indian Academy of Neurology and the NeuroRehabilitation subsection for giving me this opportunity to be part of NeuroRehab Pathshala. Today, I'll be sharing some practical perspectives on vestibular rehabilitation in real patients, how we translate the science into clinical decision making. Thank you once again for having me. Let's get started. Just a minute. Okay. So, disclosures, no conflict of interest, and informed consent was obtained for all data and imaging shown today. So this is the outline of talk. Quickly, we'll walk through our clinical approach, why treatment needs to be holistic, then one detailed case from intake to outcome, and close with a contrasting case and key takeaways. So this is our clinical approach. Every patient goes through the same 4 steps. We start with detailed history and exam, followed by vestibular testing, which then helps us map the functional deficit. And then we design an individualized rehabilitation plan. So before the case, a framing point I'll come back to at the end. Recovery in these presentations often needs a more than rehab alone approach. So these 4 are the ones relevant to today's patients: lifestyle, medication, CBT and NLP based work, and vestibular rehab. But they are not a fixed checklist, and they are not in any order of importance. Different patients need different combinations. Some need only rehab, some need rehab plus medication, others need all 4 or additional pillars entirely, like dietary modifications. It depends entirely on the diagnosis and the individual presentation. So for this patient specifically that I will be discussing, these 4 applied. I'll start with lifestyle, since that's the one constant across a patient's life. Sleep, activity, and symptom monitoring are ongoing processes. And I'll flag now, rehab outcomes themselves depend on this. We saw this play out clearly with a patient of ours recently. So this was during the World Cup finals, the FIFA World Cup finals that were going on. So the matches ran late into the night. And on the days this particular patient stayed up watching the matches and slept poorly, he had come in for a session and he'd be noticeably worse. On the days he kept his sleep timing, he did better. So the same rehab, same protocol was followed, but the difference was entirely his sleep pattern. Medication is next, followed by the CBT NLP methods like breathing techniques, compassionate body scan, cognitive reframing, and that is followed by vestibular rehabilitation, which is the focus of today's talk. So a patient introduction. This was a 52-year-old male. He had severe vertigo with vomiting a month ago, which lasted for 4 to 5 days. And it was followed by persistent imbalance and motion sensitivity. He had dizziness, especially when walking in visually busy environments, and with rapid head movements and quick positional changes. So it was a classic post-acute picture. The question was, what was actually going on underneath it? So these were his objective assessment scores at baseline. Every single measure came back severe. DHI 68 on 100, NPQ 53 on 72, PHQ 9 20, GAD 7 19, and VIVAS 83 on 90. So this wasn't one domain driving the picture. Vestibular handicap, visual dependence, mood, and anxiety were all maximally impaired at once. So now we look at this video. So you will see that on his right ear, there are right beats, but the left ear, there are no left beats. There are absence of left beats. And then right roll showed right torsional component, but left roll, the torsional component was absent. And this is his posterography at baseline. I'll come back to this posterography because it tells an important story. Here's the key finding. Left lateral canal, gain of 0, complete loss. The right side was largely preserved with right posterior canal hypofunction. So it was a complete left unilateral vestibulopathy with right posterior canal hypofunction. So this was our rehabilitation approach. So I'll go one by one. Gaze stabilization, VOR adaptation, and substitution exercises. So here we have two mechanisms combined into one because the VHIT showed two different pictures. Left anterior and posterior canals had reduced but real residual gain, enough for the brain to adapt around. So we used standard VOR adaptation there. But left lateral canal showed complete loss, gain of 0. So there was nothing to adapt. So for that specific direction, we used an eye-head substitution technique in which the patient saccades to the target before the head turns to follow, which trains a voluntary corrective response since the reflex itself isn't available. Then comes dynamic gait and vestibulospinal retraining, which addresses the postural instability and rebuilding confidence in his functional daily movements. Then comes sensory reweighing therapy, training the brain to appropriately use visual and somatosensory inputs in the absence of reliable vestibular inputs. Then comes visual motion desensitization, which directly targets the motion sensitivity and visual vertigo this patient was experiencing in busy environments. Then comes habituation exercises for the persistent motion sensitivity. he experienced using graded repeated exposure to provocative movements. And finally, counseling regarding compensation expectations and recovery pacing, because we need to set realistic timelines with our patients, because it is just as important as the exercise themselves. And now I will show this, we will see videos which depict these approaches. So here, the patient is doing VR1, VR exercises while walking, horizontal and vertical. And you can see while doing the horizontal turns, his head is slightly tipped in front so that it stimulates the lateral canal more and better. Then we addressed his visual motion desensitization by exposing him to optokinetic stripe exposure. Then we addressed the sensory reweighing. Then the VOR1 with single leg foot taps to cones, which address the dynamic balance with gaze fixation maintained throughout. Medicine ball catch and throw with trunk rotation. Here the pillar addressed are balance and gait retraining and habituation for motion sensitivity. Wobble board multi-directional weight shifts. Again, we are addressing sensory reweighing here. Ball throws against wall with head turns, eyes fixed on ball. This combines VOR training with dynamic visual tracking. And we also had uneven surface walking, VR socket goalkeeper challenge, sinusoidal rotation on rotary chair, VNG saccade and pursuit training, and a few others, each mapped to their distinctive pillar. Now, this is his oculomotor testing post-rehab. So now you will see that on right here there is right beats as before, and on left here you can see the appearance of left beats now. It's not still very distinct, but you can see that it started appearing. Even the torsional component. The left roll, you can see the torsional component starting to appear like the. So this is not just symptomatic improvement. This is measurable objective evidence of central compensation taking place. Now, this is the sensory reweighing story. Baseline sway ellipse of 1.66 square centimeter on stable surface, eyes open, rising to 208.81 square centimeters on cushion surface, eyes closed. That's the hallmark of sensory conflict pattern. And post-rehabilitation, every condition improved. Stable surface, eyes closed, dropped by half. And even the worst case condition came down from 208 to 188 square centimeter. So there was reduced postural sway across all the 4 outcomes. And the objective vestibular picture, right posterior, left anterior, and left posterior all showed modest gain increases alongside the appearance of corrective saccades that weren't there at baseline. And left lateral, the one that started at 0, it didn't fully normalize, but its saccade latency shortened. And the corrective saccades became more organized. So these are the hallmarks of active central compensation. And it was not just the objective outcomes, the patient felt it too. The subjective outcomes also improved. And these numbers pull it together. The DHI went down to 10 from 68, which is a 58-point reduction. NPQ score went down to 4 from 53, which is a 49-point reduction. PHQ 9 down to 4 from 20, GAD 7 down to 13 from 19, and Viva score down to 7 from 83. Every domain improved and improved substantially because every domain was actually treated. So now we will go back to that 4-pillar framework that I discussed in the beginning. This is a contrasting case. Let's call this patient patient 2. This patient received, this was his baseline V hits. And you can see this patient, I have written it here as well so that it's more easy to read. So at baseline, he had bilateral lateral canal hypofunction and bilateral posterior canal hypofunction. And post-rehab 6 weeks, you can see that all the 4 canals showed meaningful gains, and the right posterior canal even normalized in its gain. But if you see the subjective symptom burden increase, the DHI increased from 32 to 38, NPQ from 23 to 28, and VIVAS from 29 to 32. So why did this happen? Is because this patient declined the medications and the lifestyle modifications and CBT techniques were not adopted. So because of only addressing the rehabilitation pillar, he showed objective improvement. But because he did not adopt the other pillars that were necessary for him, his the subjective burden increased. Okay. So the key takeaway points here are vestibular rehabilitation works. It is the mainstay of treatment in vestibulopathies. Both cases today showed real objective vestibular improvement with targeted rehab, from complete canal loss in patient 1 to bilateral involvement in patient 2. Point 2, recovery needs a holistic patient-specific approach, not one fixed set of pillars. Patient 1 needed and received all 4 and improved across every domain. Patient 2 received rehab only, and while his vestibular gains improved, his dizziness, handicap, visual dependence, and triple PD type symptoms all got worse. Then thorough assessment drives individualized rehab, not generic protocols. Every exercise in this talk was chosen because a specific finding pointed to it. The eye-head technique for the canal with zero residual gain, sensory reweighing for the posterography pattern, visual motion work for the NPQ severity. None of it was standard package applied by default. The assessment is what tells you which pillars and which exercises a given patient actually needs. And point 4, it's never too late to start. The patient 1 here began his rehabilitation journey with us in the subacute phase, and patient 2 began a year after onset. Both showed real measurable objective gains. Late presentation is not a reason to withhold rehab. It's still worth doing rehab. With that, I end my presentation. Thank you so much.
Thank you very much, ma'am, for the wonderful case presentations that emphasizes that vestibular rehabilitation is of utmost importance in getting these patients back on track. And we have few more questions that was posted as we started the second talk. And shall we take those questions, sir and ma'am?
I think it is better to take so that you can have the quiz later on.
Okay, sir, sure, sir. And is there any one test which can distinguish psychiatric vertigo from organic vertigo? To Dr. Vishal, sir?
Yeah. So it's a clinical question. I would like to answer that. See, basically, the you have to do the scorings. For psychiatric diagnosis, there is no testing. We have to do the generalized anxiety score, like disorder score, that is GAD-7 and PHQ-9 or HADS. So you have to do specific scales which are important for diagnosis of psychiatric disorder. There is no specific test. An organic disorder, yes, testing can supplement, but most important thing is history taking, even in organic as well as psychiatric. The most of the diagnosis you can achieve by history, but vestibular examination and testing is to supplement your findings. Like it will confirm that okay, it is this, because vestibular testing just gives findings. It doesn't give a diagnosis. It will show unidirectional nystagmus, suppose, but is it a diagnosis? No, we have to interpret that. So all the vestibular tests, they give findings. It's not diagnosis, and specifically for psychiatric disorder, history is very important.
Thank you, sir. And you have discussed rehab using physical therapy. How does yoga fit into the rehabilitation of patients with balance problems?
Maybe Sheetal can answer you.
Yeah, yoga usually uses a lot of breathing techniques as well. So, like I discussed in the presentation, when we talk about patients having severe emotional burden, it does help there. And also with balance, because we have to hold certain postures like static postures in yoga, it does help. But obviously, there are certain postures which do not go well with patients. So we have to, obviously have the proper assessment in the beginning, and then we can guide them into what exercises can be done and what needs to be avoided.
I suppose psychogenic vertigo could be benefited by yoga
Yes,
rather
like
than
with
the
the
true vertigo.
And the next question, sir. There is one patient who still has dizziness for 5 minutes even after applying a please maneuver.
No, it's very important to see what is the pattern of nystagmus, and if it is a right posterior canal BPPV, then Epley's maneuver is the treatment. But you need to reevaluate, because 5 minutes, if the patient has continuous symptoms, like we have to go into the depth of the history examination and see if there is any other differential diagnosis.
And would you want to add about one canal getting converted to another canal after the repositioning maneuver, sir? Could
Yeah,
be
yeah,
the reason for that, sir.
it can happen. For example, for apogeotropic posterior canal BPPV, recently we did a bascule maneuver with vibration, and we saw that it got converted into lateral canal. It can happen. Even while doing the bascule, we saw the horizontal nystagmus. So it can happen on the same, obviously on the same side. If it is happens on the same side, it is explainable.
Okay, sir. Thank you, sir. And can you please explain how do you apply Bram Daroff in a residual dizziness post BPPV?
See, I generally don't recommend it routinely. I go for specific maneuvers, but especially those people who come up with the post BPPV dizziness. In those also, they can be having short arm BPPV. We go for again positional testing, check for the half Alpike testing, inversion testing. We check whether they have non-ampullary arm BPPV. So once that is ruled out and the patient still has symptom, habituation exercises come for the rescue, and there are YouTube videos available which can show the how it should be performed. It can be performed.
And there is one question that says that you thank you for the informed webinar, and they'd like to ask, in patients with chronic dizziness where vestibular, visual, and cervicogenic components coexist, how do you clinically prioritize which system is the primary driver of the symptom and therefore the target of the rehabilitation upfront?
It's a very nice question. So nowadays, what is happening is it's not just about central, peripheral, or something. It's very important to identify the components of involvement. I see that there are patients who have underlying uncompensated vestibulopathies. They have additional central component like vestibular migraine. They have cervicogenic component. They have functional component with triple PD. They have emotional component like they have anxiety, depression. So patients come with multiple components, and it's very important to, rather than trying to see what is the mechanism, it's very important to act on all of them, like vestibular migraine being treated by its specific treatment, vestibulopathy treated by rehab, which also treats the neck issues. So it's about component. It's not about neck is causing vestibulopathy. It's about whole entire thing is causing, symptoms in the given patient and reduction of quality of life. So but of course, there will be one particular mechanism. Many a times it is a vestibular migraine leading to endolymphatic high drops, causing the vestibulopathy. It is because it is not getting treated, it will lead to emotional dysregulation. It will lead to triple PD symptoms, and these patients have neck muscle spasm because of underlying, and migraine itself can trigger neck pain. Vestibulopathies can cause activation of cervicocolic reflex. So they have different components. So we have to work on all the components.
Okay, sir, I'll take the next two questions together. Can you shed light on cervicogenic vertigo? How to differentiate PPPD from cervicogenic vertigo and BPPV?
Okay. Cervicogenic vertigo. If we look at what is the most controversial question or burning question in vestibular is cervicogenic vertigo, but it has been solved by Barani Society. They came up with 3 years ago. They came up with a consensus statement that it is one of the component, but it is not the cause. May not be a cause, but it is like it may not be per se causing vertigo. Of course, the proprioceptive component is important, and many vestibular disorders have neck pain as an associated symptom. So it is association rather than a neck pain causing the dizziness. And the second question was triple PD versus BPPV.
Triple PD from cervicogenic vertigo and BPPV.
See, BPPV is clear to differentiate. That is positional vertigo occurring in particular positions, like when we are doing the positional testing. So I feel that because it's an episodic triggered syndrome, it is out. So cervicogenic and triple PD, what happens in triple PD? Many patients have body vigilance and they are using, they are very vigilant and they don't want even the natural body sway. So naturally they stiffen their muscles and they have neck pain because just imagine you are standing at height, and so you naturally we tighten our body. So same thing they are experiencing when they are walking, standing. They are tightening their muscles because they feel there is a threat to their balance. So they have very commonly neck pain. So it's triple PD which is triggering certain mechanisms and causing neck pain rather than cervicogenic vertigo. And I would recommend everyone to read that Barani Society consensus on cervicogenic dizziness. They have solved this, burning question.
Is there any better or quicker way to differentiate between a lateral canal light cupula and a pseudocupula?
The light cupular syndrome is very common. Very common means it should be considered not very common. It's not most common is BPPV, of course. Then comes the pseudo BPPV, that is vestibular migraine presenting as positional vertigo. And if in certain patients, if you can find a null point, these patients can present with recurrent positional vertigo, not able to reposition by maneuvers, and you can find out the null plane, that is light cupula syndrome. So I hope I answered that question.
Can we use Nintendo Wii Fit with balance board for vestibular rehabilitation?
Yes, of course, you can do progress, but start with, slow, and you can progress. Maybe Dr. Sheetal can answer this.
Yeah, like with virtual reality, we have to be very careful because we have seen like patients getting worse with it. So I always try to, be very cautious with it. So even if the patient on a given day says that they can go on and they can do it for like half an hour, I don't advise it I always try to keep it in short sessions initially, and then depending on how the patient is responding to the treatment, then I gradually, in the following sessions, I scale it up depending on how they're feeling. So they can be used, but you have to be very cautious while using these treatment modalities.
And are people with vestibular disorder be allowed to drive?
It depends on what kind of vestibular disorder they have. For example, like MDDS, Marley-Barkman syndrome, they feel good when they are driving or in a vehicle with passive motion, as opposed to like for example Meniere's disease or vestibulopathies. Meniere's disease, one of the trigger is a long drive. It can trigger. I have seen patients who get triggered by that. Especially the driving needs head movements. If the patient has head motion induced dizziness, definitely they should avoid. And BPPV usually happens with gravity related head changes. So there should not be any issue. But it's very important that until the vestibular disorder settles, they should be asked not to drive, because until they are symptomatically better and they are, confident of driving.
Gohan, we should now move to the last talk and then take
Okay,
the
sir.
further.
Okay, sir. And so we will proceed to the third talk where Dr. Srinivas Dorshala, who after having an extensive session on vestibular testing and rehabilitation today in Bangalore, is back again with us in NeuroRehab Pathshala for teaching us how to make meaning out of the traces and curves in VNG. Over to you, Dr. Srinivas Dorshala, sir.
Sir, very good evening to you. Confirm that you can see talk very brief. So basically, what exactly is video nystagmography or cranioculography has been now call it, is that we take just to show how it looks like. You can see the slide. So there is a goggle that the person wears, and then I'll go into the details. And what exactly happens here is the goggle that the individual wears has inbuilt cameras, and the cameras look into the eye. So what you are seeing here is the eye. And in the right, in the center of the eye, depending on whether you are looking in the a joint from a laptop uh, or a mobile, you can see there is a small plus mark that is marked right in the center of the pupil. So as the eye moves right and left, that plus mark moves with the eye. So this is a computer vision algorithm that picks up the center of the pupil and moves with the eye. So wherever the eye moves, that way this goes. So basically, this is the entire idea of cranioculography or advanced version of video nystagmography. Specifically, this particular thing has been taken to show you, because whenever you read a book about video nystagmography, the books tell that the person should not have any eye makeup or any mascara or anything like that, because books have been written mostly by foreign authors, most of them, because they don't have access to good quality equipment. They have shitty equipment. That is why they write that kind of books. Whereas the equipment that we make here in India is the world's best. It doesn't matter what happens, whether there is a mascara or there is no mascara or whatever it is. And I have a lot of pride in telling that this is the equipment made by me, and I don't think I am promoting anybody, because there is no harm in promoting my country by telling my country makes this kind of equipment. It is Ecuador MedTech. Okay, this is the most important thing. And I have no shame in telling this. Okay, so this is the way I want to start off. Okay, there is no need to appear neutral or whatever here. We make the best equipment, and that is what I want to take this year. This is the number one thing. So now what are the things that you do? And later on, because we need to know the clinical context based on what we do. Okay. So here you say there is what is shown here is a head shaking test. So what is shown here in head shaking test is we shake the head, we can see in the same video the head movement, and you can see the nystagmus of the eye. You can see an eye movement showing a nystagmic movement. So what exactly is video nystagmography is, in addition to seeing this video, okay, in addition to seeing this video, we can graphically plot that video, okay. So what, graphically plot that video. So now we are seeing something else like a short arm posterior canal BPPV. This is like the head is going down, and then what are the different applications is more important before we get into how to read the graph. So I'm just showing the different applications. So here we are seeing a patient putting the head down, and then the person gets into a Dixal-pike position on the left side. You see nothing. Then we lift the head up a little bit. When we lift the head up, you start seeing an upbeating nystagmus. So this is typical of short arm posterior canal BPPV, where on lifting the head up is when you start seeing this upbeating nystagmus. Okay, this is one variety of benign paroxysmal positional vertigo. So this is the context. Okay, there are so many things that you can do with this. You can put the patient into different position. See here, this one is a Bowendia maneuver where you put the head down. When you put the head down and you do the maneuver, still what is happening to the patient's eyes can be seen with this. Without this equipment, in what posture can you see the eye when the patient's head is put down? You cannot. That is why you need a goggle which moves with the patient's head and still displays things on the TV monitor so that you can have a straight back and still watch this one. This is the beauty of this particular equipment, okay, of video nystagmography as such, and video nystagmography with head tracking, simultaneous head tracking. Nowadays, what we have added for this is even a pupillary assessment. So here you see pupillary size increasing and decreasing. That also is graphically plotted. We have written a beautiful book on this. It is called Pupillometry book. That is also available. Okay. So now I will come to the thing proper. So what exactly is video nystagmography is, you just look at this. The eyes are moving right and left, right and left. If I ask somebody to tell what is wrong, maybe somebody will tell, look at the eye on left gaze, there is a left beating nystagmus. That's it. More than that, even if you give 10 minutes of timing also, I've done this in multiple big conferences also. More than this, it is very difficult for a naked eye to tell what exactly is wrong with this other eye, the eye movement. But the moment you see the graph of the same eye movement, what you see here is the top line, top graph is red, top graph belongs to the right eye, bottom graph belongs to the left eye, and you see the top graph shows a curving which the bottom graph does not show. That's all. What it means, we will understand later, but you see the two graphs are not different. The graph moves in a different way here, the graph moves in a different way here. That's all it is. Now, what exactly? Now, with that clinical background and context, I'm going to tell you what is video nystagmography. Video nystagmography means, you know what is photography. Photography means, graphy stands for tracing or writing. Photos means light. So tracing or writing with light is photography. Okay. This is the most important thing. What is electrocardiography? Electrocardiography is, graphy is again writing the heart using the electricity of the heart. Electronystagmography is again writing with using the corneoretinal potential. That used to be electronystagmography. Whereas video nystagmography or video oculography is different, because here computer vision algorithm looks into the video, finds what is the center of the pupil, and then gives you a tracing. That is video nystagmography system. That's all. So what is the technique of video nystagmography is simple. The aim is to be able to see the subject's eye even in complete darkness. Why this is needed is, lot of eye movement abnormalities can be suppressed by fixation. When the person is allowed to see, that nystagmus is not seen. Okay. So whereas if you close the eyes, okay, if you close with the goggle, complete darkness is there, the person does not have anything to see. Okay, anything to see. The subject being examined wears a set of goggles. The eyes are illuminated with infrared light. What is the beauty of infrared light? Patient cannot see that light, but camera can see the patient's eyes. Infrared cameras capture the villi of the eyes. Special algorithms detect the center of the pupil and pupil center marks with the eye. Tracing of the pupil center mark is obtained. This is the video nystagmography. So to show in an animation, when This is the eye. The center pupil marker is moving with the eye. This is the entire idea of video nystagmography. So when the eye moves, this moves. This is going to be plotted. How it is going to be plotted? There is a convention. The eye can move up and down, eye can move right and left, eye can move torsionally also. So because of the eye can move in different ways, for right and left movement, there is going to be one color given. For up and down movement, there is going to be another color given. So when the eye moves towards the right, there is going to be one line for rightward movement. That line for horizontal movement will go up when the eye goes to the right. That line for horizontal movement will go down when the eye goes to the left. That line for horizontal, vertical movement, any line, whichever you choose, depending on the maker's convention, when the eye goes up, there is going to be a separate tracing for the vertical movement. The vertical trace will go up. There's going to be a separate tracing for downward movement. The same tracing for vertical movement. Up will be, the line will go up. When the line goes down, the thing goes down. This is the critical part. Now let us see draw one example. See, the eye went to the right and came back to the center. See, eye went to the right and came back to the center. That's all it is. Now, how does the graph show? The red line we are using for horizontal. When it goes to the right, the line has to go up and then come back. That's all. So I went up and I went down. Up means I came to the right. Down means I went to the left. Now you may be asking, what is right here? What is left here? Why do I say now it was right? Why do I say it is now to the center? Why did I tell the eye moved to the right? You could tell it could have been moved to the left. The convention in video nystagmography is as if the patient is facing you. If the patient is facing you, this goes to the right and this comes back. This goes to the right and this comes back. Patient is facing you. That is the meaning. So when the patient is facing you, this goes to the right and this comes back. This is the eyeball going to this side is going to the right. That's all is the convention. So when the eye goes to the right, the graph goes up and the graph comes down. That is all it is. Okay. And see here. Now eye goes to the right, stopped there, eye goes to the left and came down. So how does this is shown? So it started in the center, it went to the right, it stopped there for some time, it went all the way to the left, it stopped there for some time and it came back to the center. You see this again. Stopped, went back to the left, stopped and then came back to the center. This is the entire thing. In the graph, how do you show? I went to the right, that is graph going up means I went to the right. On the right, on the top, the graph was flat, which means I did not move there. Then I came down all the way to the left. It crossed the line, this baseline, which means it went to the left. Again, it came flat and then again it came to the center. So this is the entire idea of this. How to represent graph. Now, when you look at the vertical movement, when it comes up and down, the same red line will not be sufficient for showing vertical movement. So convention uses another color. So use another color for vertical movement. When I went up, went up. When I came down, the graph went down. That's all it meant. The conclusion. Oblique movement involves a side-to-side movement and an up and down. Both together, I went to the obliquity. See here. Both of them together, I went oblique. That's it. So both of them together, I went oblique. Here you see, I went to the left and came to the center. So this red line went down and came back. I went up and came down. This is red line, green line. The line for vertical went up and came down. So if you want to show again, see this graph, see this video. When you see this video, went up and came down. If you vertically look at it, it went up and came down. If you horizontally look at it, went to the left and came to the center. So the same is traced here. Horizontal trace went to the left and came to the center. Vertical trace went up and came down. That's all. Now this is very simple. Now stock market. If you see a stock market graph also will look like this. If the prices are going up, the worm goes up, but the prices are coming down, the worm goes down. If the prices are going up fast, then the worm goes up very steeply. If the prices are going up slowly, you see it is more flatly. So the steeper line means the faster movement. Even in eye movement, if you see a jerk type, if you see a sawtooth pattern, it is going up and down, up and down, up and down. Sawtooth pattern means there is a nystagmus. That's all. So sawtooth pattern simply tells that there is a nystagmus. Now, how do you compare velocities? How do you say this is fast or this is not fast or whatever between two nystagmuses? We compare the steepness. If one line is very steep, other line is shallow, the steep line is the line that tells. If you see a sawtooth pattern, that means a nystagmus. You saw the nystagmus video, so many videos. I go slowly to one side and fast to one side. So one steep line and one shallow line, one steep line and one shallow line, if you see, that is a nystagmus. So if you see a sawtooth pattern, it means nystagmus. Jerk nystagmus means sawtooth pattern. So sawtooth pattern means jerk nystagmus. Line go up. I mean, the steepness of the line tells how fast the eye movement is there. If it is very steep, exactly like this thing, exactly like nystagmus. I mean, what is that? This pattern, exactly like stock market. This is all video nystagmography is about. With that, you can do a PhD thesis about different eye movement patterns. But the most important thing is to see, understand this particular thing. And this is my submission. That's all. There was a question before that, where do we get Frenzel goggles and all of those things? I want to answer. We make Frenzel goggles. The cost of the Frenzel goggles is 60,000 Indian rupees. It is a 20 diopter wearable goggles with inbuilt light source to it. So there is an inbuilt light source in the rechargeable 20 diopter lens. Okay. So that is the thing. This is my phone number if somebody wants to contact. And that goggle is also made by us. Because it is made in India, you don't have to bother about service or whatever, anything is there. We are there to service and whatever it is. Okay. And they are, again, as I said, among the best. Okay. So this is the only submission about this thing. If you want to learn more about video nystagmography, how to learn more and all of those things, you are always welcome. We encourage people to come be observers in our center. If you want to do, you can do a course which we do in a Enopaya Medical College. It's a big course. It's a 3-year, but it has a huge waiting list. For the next batch, we have about a waiting list of about 400 people. But then we try to accommodate as much as possible, because our mission is to teach people and take this, popularize this vestibular science. So thank you all. Thank you so much.
Sir, thank you very much for the brief talk and comprehensively covering how VNG measures. And that will kindle more interest in our audience today to learn more about VNG, more and more about vestibular rehabilitation. And thank you to all the three faculties for bringing us vestibular rehabilitation into one platform in NeuroRehab Pathshala. And with that, I request words from the chair, Dr. Nirmal Surya sir.
Thank you, Guan. I see a lot of interest. There are many more questions are there, and I know that people are very keen to learn. We got 5 minutes, so we should take few questions which are burning, particularly for if there's a question from Dr. Dorsala. A compliment from one of the gentlemen that we had the eyes on video but never knew where the head was going until Dorsala sir brought them together with COJ.
Thank you, sir.
I think compliment to you, sir.
Thank you, sir.
Can you also give the answer to how long does patient need rehabilitation in PPD and vestibulopathy?
So this question is for me?
Yeah.
Okay. So
if you can
triple
answer,
PD
otherwise.
Okay. So triple PD is one case, one diagnosis which I make very occasionally. Okay. In my practice, triple PD diagnosis is made for probably one patient once in 6 months. Okay. Once in 6 months, that rare. Okay. It's not like bragging in conferences or whatever it is. Lot of these people who actually are given a label of triple PD have a lot of psychological issues. There are personal traumas and all of those things. When you actually deal with all of this, you will know that when we really open up, most of the people have some other issues which we can actually deal with. Proper triple PD patients, it is not like you just discharge them off. Okay, it is not like 3 months, 6 months, and then they go off. We have a lot of patients who, after rehabilitation for 2 months, 3 months, they become very independent, they start walking, but then again they come back and then they take rehabilitation again. It is like they become lifelong friends. So that is the thing. And we should only thing that we can tell is we are always available. That is the most important thing in triple PD.
Thank you. Thank you very much, sir. I think vestibular rehabilitation is something which is very interesting, and if the right patient is treated by right person, is very rewarding. Uh, of course, it is not temporary. Those who have a sensitive vestibular system, as you know, we talk about compass. It is always going to give them trouble when this going to stimulate them. So, like you do the exercises in your life. You build up your weaker part. Similarly, if you have a vestibular system disturbance, it will require a long-term management, long-term rehabilitation rather than a short-term correction. Yes, there are maneuvers, there are repositioning which can be like dramatic, as Vishal has said, but in long term, you need to really discipline yourself and do the regular exercises. I'm extremely happy that we had a good number of people who were interested in this. Neuro rehabilitation is challenging. It is a branch which was not much known. In fact, it was me who brought the vestibular rehabilitation into the neuro rehab first time ever in 2018 in the World Congress of Neuro Rehabilitation, where we did a live case, and I know that Sudhir that time did a wonderful case there, and the people were overflowing even outside the hall, and they just wanted to go in. I realized that this is a subject which needs to give an importance in the neuro rehab. And now, for last so many years, we have been regularly, training the people. Each and every IFNR conference has a session or a workshop on vestibular rehabilitation. So those who really put the question when and where, I'm pretty sure the next IFNR Arun, which is doing in April at Coimbatore, would also have a vestibular rehabilitation session, and you all can learn. And I'm sure not only Vishal in Dubai, but in India, there are a couple of centers where you can go and take the training, maybe in Pune, maybe in Udaipur. Of course, you have to show the interest. You can always write to the Vishal or Sudhir, who can guide you where you can go for your training. With that note, I once again hand over to Guhan and Ramakant for taking this great initiation and taking the subjects which are unheard, unknown, and untalked about. And you could also highlight what is coming next for next two sessions so that people can keep themselves free for that session.
Yes, sir. And this time we have planned ahead, and because the next Neuro Rehab Pathshala is happening on September 4th, Friday evening, and that's the message we have from the Presidium of the IANS. It should not draw very close to the National Conference of the Indian Academy of Neurology. So we are taking it in the first week of September, and the chair of the Neuro Rehab Pathshala, Dr. Nirmal Surya sir, and every one of us together, we follow his path, and the next program is a very exciting one. And let me break that surprise. It is how to tame neuroplasticity using neuromodulation, and that would be a beginner's guide. We don't want to delve into the depths of it. That would be a beginner guide, and we have our speaker, Dr. Nicodemus from Perth, Dr. Saurabh from Delhi, and Dr. Sanjeevani Kamble from Maharashtra. And in fact, Dr. Nicodemus is attending this session as a attendee. I think it's to know what it looks like in the Neuro Rehab Pathshala. And until then, we will join again. And I request few words from Dr. Ramkant Yadav, sir.
And tell about the
Before we
quiz
close.
also.
Sir?
Quiz. Last quiz
Ah,
result and
so the last quiz result was posted in the group, sir. We'll summarize all the results together and post it again in the group. And due to lack of time, we are unable to take the gamified quiz now. We will have a predetermined schedule, and we will post the QR code in the NeuroRehab Pathshala group, WhatsApp group, where you can participate in the quiz, and it will be open for a short period of time to avoid usage of artificial intelligence. And with that, I request a few words from Dr. Ramkant Yadav, sir, the convener of the NeuroRehab subsection of the Indian Academy of Neurology.
Thank you, Dr. Guhan. As Dr. Nirmal Surya rightly said, that vestibular rehabilitation is very much neglected part of rehabilitation, especially for the neurophysicians. They give emphasis on motor rehabilitation and other things, but they neglect rehabilitation. And I'm very glad that Dr. Vishal and Dr. Sheetal are doing wonderful job. And they have set up a center in Dubai. And with their lecture, we all have become more wiser. And Dr. Srinivas is also doing very good job being a ENT surgeon. But for neurophysician, it was an eye-opener. All three lectures were eye-opener. And I'm sure that in future, this type of Pathshalas will make us more knowledgeable. Thank you very much. Thank you, Dr. Nirmal Surya, sir, for guiding us for this type of events.
Thank you, sir. And with that, we come to the end. And I would take this opportunity to thank Dr. Nirmal Surya, sir, the Presidium of the Indian Academy of Neurology, the President of IAN, Dr. Lakshmi Narasimhan, sir, Secretary of IAN, Dr. Meenakshi Sundaram, sir, and the President-elect, Dr. Sudhir Kothari, sir, the vestibular man himself, and the faculties, Dr. Vishal Power, Dr. Sheetal ma'am, and Dr. Srinivas Dorshala, sir, and Dr. Ramkant Yadav, sir, and all the wonderful delegates who have been very interactive today. And meet you all again on September 4th. Until then, goodbye from the NeuroRehab subsection of the Indian Academy of Neurology.
Thank you.
Thank you.
Thank you.
Thank you.